everyone, welcome to our March webinar for NASGP members. We're really lucky today to be joined by Rachel Ainley and Pearl Avery from Crohn's and Colitis UK, who will be talking about the National Primary Care Diagnostic Pathway for Lower GI Symptoms, as well as their a new sort of cross-partnership website called What's Up With My Gut. Thank you very much for giving up time for joining us. If you would like to raise any questions at the end, you can ask Rachel and Pearl directly by unmuting, and you can also pop questions in the chat. Without further ado, Rachel, Pearl, thanks for joining us. Over to you.
Sally, great to have everyone on call this afternoon. So I'm Rachel. I'm the head of research and health services at Crohn's and Colitis UK. And Pearl, my colleague, is going to be speaking to you slightly later. So I'm going to give an introduction to the work that we've done with this collaboration of charities and professional bodies to develop the National Primary Care Diagnostic Pathway for Lower GI Symptoms, which is one and the same thing as the What's Up With My Gut website. So the What's Up With My Gut website hosts the all the resources that were developed as part of this work to develop a national diagnostic pathway. So, where did this come from? A couple of years ago, there was recognition amongst different charities representing people with lower GI symptoms that we needed to do more to be joined up and to actually think about the person who's in front of the clinician when they come to visit a clinician, and the person who's going through that diagnostic journey. Lots of support and guidance is very condition specific, rather than really putting the person who is experiencing the symptoms at the centre of that diagnostic journey. So the National Diagnostic Pathway Group was set up to develop a primary care diagnostic pathway for screening and testing of lower GI symptoms, aligned with the cancer pathway for both adults and children. But also importantly, to develop a toolkit to support people living with symptoms and going through that diagnostic journey through that journey. And both of those resources are hosted on the What's Up With My Gut website. In terms of developing it, it was a broad collaboration of charities and professional bodies, people with lived experience, primary care practitioners, and we're delighted that it's been endorsed by a wide number of professional partners, including the Royal College of GPs. The microsite, which is where all of the resources are hosted, is live. It went live last summer, and we encourage you all to take a look, play around with it, let us know what you think of the resources, and all of the information about it is on there. Anyone can link directly to this website. There's one place where all the resources are housed and we can update them, but it's maintained by Crohn's and Colitis UK, where I work, on behalf of the partnership. As I mentioned, the website, it's there. We want it to be used. We want it to be really accessible and usable for everyone out in primary care. We have the adult pathway, we have the children's pathway, and if you scan the QR codes that are on these slides, they'll take you directly to the microsite. This is what the healthcare professional facing pathway looks like. It talks the person that's using it through the red flag symptoms for both colorectal and ovarian cancer, common symptoms presenting GI, lower GI conditions, guides the practitioner through what they should be thinking about in terms of the main conditions that we're thinking about here: inflammatory bowel disease, celiac disease, irritable bowel syndrome. It then goes on to list a number of tests that could be considered and what to do as a result of those investigations. And importantly, as always, the safety netting, what to consider, what to think about if things aren't quite adding up or you're not quite sure. So it's a very user-friendly, aimed to be very easy, quick to use in a consultation, and a reference and also educational kind of support tool for people in primary care. Mentioned there's a separate pediatric pathway. Again, looks very similar to the adult pathway, but tailored in order to reflect the differences in presentation, investigations, and treatment for those under 18s. I mentioned, again, that was developed by the project group, charities and patients, and follows that structure of the diagnostic pathway. It's had a wide range of input from people both living with the conditions, but also waiting for a diagnosis and at present going through that diagnostic journey. We've had really good feedback actually from people that have used it when they've been unsure what they should be advocating for themselves in order to have better conversations with their primary care practitioner and help them through that diagnosis journey. UK also lead the IBD UK Alliance, and one of the big things that we launched last year was a report about the state of IBD care across the UK, Crohn's and colitis care in the UK. It was a huge number of patients took part in the survey, lots of IBD services took part in a self-assessment. And one of the key recommendations from this was the implementation of the National Primary Care Diagnostic Pathway for Low GI Symptoms, which is a bit of a mouthful, as part of a number of recommendations about how to improve diagnosis for people with IBD. We know that people are waiting too long for their diagnosis. We know that it's really a challenging time for the NHS out there, and we really hope that this tool will help people to get the right test at the right time when they're going through that diagnosis journey. As you can see, there's a number of other recommendations there around diagnosis, including raising awareness of symptoms of IBD, getting people to think about symptoms which they may be sitting at home with and not thinking about. So getting people really to advocate for themselves. I'm going to hand over to Pearl now to talk a bit more and sort of bring this to life. You've had the background from me, and she's going to bring it to life, hopefully.
Thank you, Rachel. I'm Pearl Avery. I am an IBD nurse by background, and I currently work in primary care as a consultant nurse practitioner with a special interest in gastroenterology. I'm probably quite a rarity at the moment, but there's a growing number of us. At least 2 others that I know of have come out into primary care with their gastro knowledge, with an aim to provide some very targeted support for people with gastro conditions, including inflammatory bowel disease. So really, I've been asked, I was lucky enough to be involved in the development of this pathway, and I think back to the focus on patients being a part of this development, really, because that was the important thing that came from this. But it's really important to then sort of bring that back and focus in what are the current system priorities in gastroenterology and colorectal disease, because these are the things that we're dealing with on a daily basis in terms of how are we going to deliver better care for people with gastro conditions. So I did a little recce around my local system to see what was going on in terms of what the priorities were. And most of the priorities were based around improving cancer outcomes. There wasn't any mention of the getting it right first time improvements required in gastroenterology. And understandably, because of the sheer numbers of people waiting for a colonoscopy, there was a focus on endoscopy. So no mention of IBD, no mention of celiac disease, diverticular disease. Recently, some new James Lind Alliance priorities for research have been set in diverticular disease. So just showing how that's impacting people. And of course, IBS. So it's quite a challenge, really. Rachel, could you do next slide? So we've already talked about the symptoms, red flag symptoms in particular, that perhaps are the ones that are sitting in our minds in primary care when we see a patient that comes in. But I think it doesn't really necessarily reflect the experience of the person sitting in front of you. And it can lead us down that 2-week wait pathway, which arguably you could say might lead towards a diagnosis, but it doesn't always. So that's a really important conversation. If we could just move forward again, please, Rachel. And again, because I just don't want to labour the point of red flags, but sometimes that's how I feel in primary care, that my head is full of those red flags and those concerns about cancer and the high mortality, morbidity conditions that we usually think about. But I think we sometimes forget about the impact of these symptoms on people. Next one, please, Rachel. And I'd just like to sort of focus your mind a little bit in the same way I think that we hope that the pathway will focus your mind as well into thinking about what it's like to live with these so-called benign conditions like inflammatory bowel disease, microscopic colitis, bile salt malabsorption, even irritable bowel syndrome. You know, just imagine having your bowels open 20 times a day. If you've ever had a bout of gastroenteritis, it's horrible and you're glad it's over. But if you have to live with that every day, only to be told, you know, time after time, you've gone to primary care, you've had lots of investigations, and some of them, you know, if they come up, they've told you you haven't got cancer, so there's nothing we can do. And that's the frustration then that patients are then told to live with the symptoms. Now, with inflammatory bowel disease, it can be a bit more straightforward. Obviously, we've got some very targeted investigations there. Can I just get you to go to the next slide, please? But still, there's a diagnosis delay in inflammatory bowel disease. And a rapid evidence review that was conducted on behalf of Crohn's and Colitis UK identified that around 40% of people wait over 6 months for a diagnosis. And that's variable across the country, with some people waiting up to 5 years for diagnosis, which I think is just intolerable. Imagine living with those symptoms for that length of time. You know, the impact of this delay on people living with IBD is loss of work, mental health decline, fatigue, isolation, acute hospital admission, which these days none of us want really, do we? Because we never know where we'll end up. We might be in a cupboard or a corridor. And I don't think that's the kind of care we want to see for patients. And ultimately, unnecessary surgery. And by unnecessary, I mean, you know, while surgery is a completely acceptable treatment option, if it is an option, a choice that's made by people, but if it's just, you know, something that's happened to them because we've let them down through the system, then I think it's unnecessary. No emergency surgery really should be considered in IBD these days. We've got treatments and options to give people choices. Next slide, please. So just thinking about that rapid evidence review again, and delays happen in both community and acute care. And I think, you know, I'm just trying to think about the language we're using these days, obviously thinking about neighbourhoods for community care and acute care as places, but really whose responsibility, you know, making sure we get this right? Well, I think it's everybody's, and it's the system's responsibility as well. So I think we need to be, you know, making the right noises in the right places, I suppose, and having the conversations to try and get changes in place, expertise where it's needed, and support. Next slide, please. So one of the things that I've learned to do probably anywhere I've practiced, and that's been around the system really. So I've worked in secondary care, in tertiary care, and now in primary care. So it sort of allowed me to think about how best to support people, and I just try and make each contact count. So as well as seeing the person in front of me and making sure that I align my practice and my consultation to what the patient's expectations are, realistic or not, I spend a bit of time checking for history of investigations or not, as the case may be. And one of the things that I've been doing most recently is challenging that diagnosis of IBS that I see coded on various systems. Because, you know, if they haven't had investigations to rule other gastric conditions out, then we can't really give them an IBS diagnosis without missing maybe the chance of actually sorting their symptoms out. Thinking about what medication a patient's on, that can be a really quick win. And then, you know, thinking about how other aspects of primary care, including community pharmacy, can support patients. And that's thinking about patients that perhaps, you know, don't look like the usual candidates for housebound, but are asking for medications to be delivered, or perhaps they're coming in and buying lots of loperamide or other over-the-counter gastric remedies like Buscopan. Next slide, please. So I already sort of alluded to the fact that I think there's a system approach to this that's required. And I think, you know, getting more gastrointestinal experience in primary care is one of the key things to do. And there's obviously some exemplars around the country with some gastro-specific training being led by the Primary Care Society of Gastroenterology, and Charlie Andrews leading on that. And we're hoping to actually spread that through the primary care workforce and include practitioners in that training in the future. So it's something that we started to talk about last week. So very new, but something that's quite exciting in terms of hoping to improve the knowledge and experience of people working in primary care. Because if you just got one person in the practice that's an expert, then they can be that resource for everybody, and hopefully increase and improve the outcome for people with gastro conditions. So access to tests, improved pathways for sure, and fit tests for diagnosis are currently being evaluated. There's some concerns over this. Currently in Scotland, there's a focus on the fit test being the priority, with calprotectin actually not being very available at all. And we have concerns because actually fecal calprotectin for inflammatory bowel disease diagnosis has been a game changer, and I think it's changed lives. So using calprotectin is a really good way of making sure patients get access to early treatment with disease-modifying agents. Next slide, please. So this little bit here about empowering patients, and I think this is one of the, again, bring it back to patient voices. Having patients involved in the development of this pathway allowed us to find out what was missing in the general knowledge of people, what questions they wanted to have been able to ask, perhaps that might have helped them to access a diagnosis. And this is really helpful. And I think we'll all agree that with you know, so much misinformation available to patients, having good quality resources like this available on the internet will only improve outcomes, including ChatGPT searches, hopefully, so that they get the good information rather than the misinformation. Next slide, please. And I suppose, you know, thinking about delay in diagnosis is a little bit of food for thought. If you've ever worked in inflammatory bowel disease, these slides are, and this figure is a regularly shown analogy of how early treatment, sometimes in the earliest possible phase, can change the outcome for patients in terms of their disease burden. And, you know, talking about disease burden, we talk about benign conditions, but inflammatory bowel disease still does lead to loss of life. Thankfully, I only know of a handful of patients that's happened to in my 20-year career. However, it has been, those patients sit with me, because I sometimes wonder if we'd managed to get it right sooner for them, would their journey have been different, and would they still be with us? And arguably, at least, you know, a half of those possibly. And I don't think we know really the impact on people's mental health. I don't know the suicide rates among people that live with intractable gastrointestinal symptoms. And I probably would argue we never will know, because most people that feel so desperate that they take their own lives over healthcare issues don't talk about them. And we all know the difficulties about talking about bowels. So it's no wonder. Can we, next slide, please? And again, you know, I focus here on ulcerative colitis. If we get it right, chances are if we get in quickly and early with treatment, we can change the disease course and switch off that inflammatory burden, and hopefully allow people to live a very normal, active life with their inflammatory bowel disease. Next slide, please. So really, it's just some references there, including the link to What's Up With My Gut, and just a few useful resources there. That's, I suppose I'd just like to, again, finish with that idea that, you know, these co-developed resources like this they're not going to be a panacea for all. I understand that. I understand there's local guidance and there's local pathways that we will have to follow. But I think what this does for me is help to focus my mind when I'm seeing a patient in front of me on the key symptoms that might be important to them. And if nothing else, if you're not going to look at the healthcare professional pathway, look at the patient pathway and see what questions that they might want to be asking, because it can open up all sorts of conversations. And if we can focus consultations back on the patient, then I think it'll be easier for us all.
Okay, actually, what I wanted to ask was in diverticulitis, sometimes if they're intractable diverticulitis, I sometimes use mesalazine. Why is it it's not used, considered as part of the inflammatory bowel disease list?
So why diverticulitis isn't?
Yeah.
Okay. I think because, you know, there's very clear diagnostic criteria for both Crohn's disease and ulcerative colitis. I mean, I could say that so the poor relation in IBDs is maybe microscopic colitis as well, because there is an argument that that is immune mediated. Diverticulitis has got a functional cause for the inflammation, so it's the pockets that are the problem. It's the pocket, the diverticulum themselves that are creating the inflammation. So it's and without them, so for instance, fistula that develop because you've got a diverticulum to the bladder will likely heal once you've dealt with the inflammation, because you're dealing with, so potentially you're having a anterior resection and that's solved the problems with the fistula. Whereas with inflammatory bowel disease, you could potentially remove the bit of bowel that's inflamed, but still end up with fistulizing disease in the rectum and perianal area, because that inflammatory process is autoimmune driven. So it's I think yeah. Does that answer?
So the fundamental difference is that the apoploic diverticularly, you have to have a exogenous, impaction of feces to create the initial inflammation.
Yeah. And you know, I mean, they do coexist sometimes, don't they? We've seen cases of ulcerative colitis and diverticulitis alongside each other. And you know, mesalazine, I imagine mesalazine working as a, so the way I always describe how mesalazine works is it's a barrier cream. If we could go on into the colon and basically apply it like a cream, then that's what we do.
Well, it's the anti-prostaglandin pathway that it.
But it's mainly trying to be protective as much as anything. So it's I think it's limited evidence in diverticulitis, to be honest. It's but yeah, it's
the only reason I ask this is because we often the vast majority of people who go who are referred to the IBD clinic end up not having IBD, but they still have these awful symptoms that when you ask the patients, well, how do they feel? Well, they tell you they're terrible. They go to the toilet, they can't do this. They're housebound, they're afraid of going out, etc. So it all symptomatically, it all reflects the IBD scale.
Yeah.
But pathologically, it doesn't. So
no. So I suppose that's when you want to think outside of IBD and thinking about, you know, making sure that if they've had a proper investigation for inflammatory bowel disease, they will have adequate biopsies to look for things like microscopic colitis, but they might not have considered things like bile salt malabsorption, pancreatic insufficiency. Usually we'll have, if they're gastroenterologists that think like that, but there are other things to be thinking about, and I think those are sometimes the conditions that will also benefit from this pathway. I mean, celiac disease is still underdiagnosed massively, and you know, particularly in children, because we're not looking for constipation necessarily as a precursor in the standard sort of presentation with celiac disease. But all of you will know and agree with me that there's a very worrying, almost an epidemic of constipation in children that I find quite disturbing, to be honest, when you have children that are turning up age 11 still unable to have their bowels open properly and normally, wearing nappies before they go into secondary care. I think, you know, somehow we've got to do better about normalising the conversations about bowels and poo, and, you know, children not being embarrassed or frightened to go to the toilet. That you know, we have to do something about that. We have to break that barrier down. It's just not fair.
Lovely, thank you.
If we don't have any more questions today, then I think it's just a really good opportunity for us to take some time to thank Pearl and Rachel for giving up their time. The presentation was very sort of info dense, and there's loads of great sort of follow-up links that we can go and explore. And particularly, Rachel, you've posted the path to a correct diagnosis page from What's Up With My Gut in the chat. It's been a real pleasure having you, so thank you very much for coming to see us today.
Thanks for asking us.
Thank you very much.